So you've got a lump and you don't like the lump, or somebody's worried about it, or somebody's bugging you to get it off. So we're here to help you evaluate that and get you past that point and maybe get it gone. So lumps in the skin that are growing on the skin usually are dealt with dermatologists. Below the skin, they can be a process that's infectious. It can be a cancer. It can be a non-cancerous growth. But below the skin, it's really hard to define what it is. So we use a few parameters around that to help us know what to do. We call it a tumor until we know otherwise what it is. And that just means it's a bump. And we're going to have to find that out. And many times we find that out only after it's been cut out. There are really common forms of tumors. One of is a sebaceous cyst. It's a deep part of the skin that accumulates sweaty fluids and oils, and it gets larger and larger. Frequently it gets infected. Many times you'll see a skin pore associated with it. And if you squeeze stuff out, you're inviting infection to come back in and take its place, and actually promotes infections. Sometimes those tumors get infected after an episode of some sort of getting bumped or some trauma. But the indication to take those out is largely to prevent them from getting infected as they get bigger and bigger. And sometimes they can achieve quite large sizes before they get infected. They have about a 1 in 1,000 chance of being cancerous. So they're all looked at under the microscope when they come out to make sure that we know what we're dealing with. If a sebaceous cyst gets infected, normally the first process is to drain the infection, get all the junk out of it, and let it heal up. It will then slowly reform again, and when it's the size of a pea or bigger, that's a good time to take it out and get rid of it before it gets infected again. Other lumps generally don't cause pain, generally don't cause infection. And if a lump is over 2 inches in diameter, the chances of cancer go up dramatically. So if you've had a small pea-sized lump that's gone to a grape-sized lump that's now a kiwi fruit, it's growing. It could be cancer, and it should be removed. If it's, however, a pea-sized lump that's been there since you were a teenager and it's not changing, the chances of it being cancer are quite low, and it can safely be observed without taking that out. Sometimes the lumps get to a size where they're compressing an adjacent nerve. That's a random thing that can occur just about anywhere and can be actually quite small lumps. But if a lump is causing pain, if it's steadily growing it's over 5 centimeters in diameter, those are lumps that we have a medical indication to get out and remove the pain, remove the question marks about it, and potentially circumvent it becoming a cancer later on. So those operations can be done under a local anesthetic or sedation depending on the size. And the principle is the same, but the closure is a little bit different depending on the size. If you've got a tumor that's only that big or smaller, usually it's just an incision directly over the lump to take it out and remove it and be done with it. If, on the other hand, it's that big, it's usually got a hump of extra tissue, extra skin over the top of it. So we'll start beyond that and cut out some of that extra skin, and then follow that under and take out the whole lump and have that all looked at under the microscope. This would be looked at under the microscope too. If you've let something get really big, the same principle applies. We've got to take out the extra skin associated with it, and then there's going to be a big gap underneath there that we'll have to reapproximate point A and point B. Usually there'll be stitches in the skin. Point A and point B will be brought together underneath by undermining skin way off to the side so that you don't end up with a great big divot where you used to have a big bump. We like to get things flat, reapproximated, so that you don't have a big hole there where we've taken out your Nerf ball tumor. So that's a flap advancement closure. The bigger the tumor, the greater chance it's cancerous, over 5 centimeters. the chance of cancer is not particularly high. It's only 1 in 200 or so. But that's too high to let it go. Clearly, if it's over 5 centimeters, it has been growing and usually continues to grow. And the larger the tumor, the greater chance it's cancerous. And we take this out, though, with the assumption that it's not cancerous because it's a 1 in 200 thing. If the tumor's 10 centimeters or so, it's still only a 1 in 50 thing. So we generally take it out as though it's not cancerous with the plan on you healing the area primarily, but we are waiting for that pathology report 4 days later. And we're generally in the habit of giving you a call, let you know what it is so you're not worrying about it anymore while you're in the healing phase. The incisions here with these stitches, you want to leave the stitches alone, particularly if it's on your back. You're going to be bearing body weight and shifting and putting force on that at nighttime. And the buried stitches that we would otherwise do on your arm with smaller things tend to pull apart in that circumstance. So you'll end up with a gush of fluid and an open wound and a hard place to take care of it on your back. So we generally leave those stitches in for about 3 weeks to let the healing pull things back together, let the healing get under good way before we're letting you take some strain on that. Lumps and bumps rarely are a cancer issue, but we need to make sure they're not a cancer issue. Sometimes they're a pain issue, but in any case, they're generally done as an outpatient operation where you come in, have your surgery, go home the same day. If it's real small, it may just be under a local anesthetic. If it's real big, you may end up with a general anesthetic or some heavy sedation so that we can numb the area up adequately. Some of these tumors are actually below the skin and below the fat, and they're in the muscle, in which case you want to be relaxed and sedated also. So we get some feel for that when you're in the clinic getting an evaluation and set the surgery up. If you can't sit still for a local anesthetic in the dental office, you might not be able to sit still for a local anesthetic here either, and talk to us about that. There might be a role for some sedation with an anesthesia provider involved with that as well. So for the most part, you end up with a small scar or a large scar where the tumor was, whether it was a large or small tumor. We'll define that. So don't let it go too long. Get rid of it, get it out of the picture, and hopefully be reassured for most of you that it is not cancer in the end. Okay, now I've got a really unpopular subject, and that is complications after surgery. All surgeries have potential complications. Some surgeries have different complications from others, but there are some that need to be watched out with every operation. One of those are things that people naturally are afraid of, and that's bleeding. For most operations, the risk of bleeding is relatively low, amounts to bruising, and rarely results in transfusion. If you have religious objections to blood products, be sure and let your surgeon know about that. But rarely do we need to proceed on with any bleeding, transfusion sort of issues in general surgery and the stuff that I'm generally doing. But there are a few things that can increase your risk of bleeding that you need to be aware of. Aspirin increases bleeding. It increases bruising substantially. And unless your doctor feels like you need to be on aspirin despite the fact that you're having surgery, most patients will be taken off of aspirin. Likewise, ibuprofen, Aleve, any of the non-steroidal anti-inflammatories also have the same effect on clotting. So we'll generally have people off of those medications for a few days before surgery. External bleeding is very obvious. If you've got a spot of blood this big on your dressing, it's probably going to stop on its own. If your dressing, however, is soaked and looks like it's continuing, you need to notify your surgeon right away. Frequently that will get better just by applying pressure. But if it doesn't, it will need to be addressed during a close time frame there. Don't be polite to your surgeon. I like that if you are, but don't wait till morning if you've been bleeding all night. That can be a real problem. and let the surgeon know if you're soaking your dressings. The other way that you know you have bleeding is something you might not think of up front. For most operations, we want you up and around the house the night of surgery. And walking is good. It prevents blood clots. It keeps you mobile. But it also gives us an early warning sign. If you're attempting to walk the night of surgery and you're pale and you're passing out, that's either a heart problem or that's internal bleeding. That's an automatic trip to the emergency room, and nobody should talk you into going to bed because you're dehydrated, you just need to rest. If you're pale and passing out, or just passing out period, when you try and walk, that's internal bleeding and needs to be evaluated that night. Call 911, call me on the way. Infections are also a risk with surgery, and anytime the intestines are cut across, there's a higher risk of infection. Wound infections are not common at Meridian Surgery Center. The risk is about 1%. If your wound is red and angry, if it's draining pussy stuff, if you're having a fever over 101, those infections symptoms are generally going to occur in the first week to 3 weeks after surgery. It's a nuisance. It might scare you, but it's probably not an emergency that requires an emergency room visit. And if you go to the emergency room, you're going to be there 10 hours. Calling the surgeon, texting a picture is the better way to do it, way faster, way cheaper, and will save you a lot of trouble. I had a patient 2 years ago who was pacing in the emergency room with this problem. He'd been there 4.5 hours. He was getting really mad. Other people were going ahead of him. He wasn't getting any attention. And he just went, I'm supposed to be calling Dr. Wright. What am I doing here? And we had it all figured out for him within 15 minutes. So be aware, the emergency room isn't generally the place for that kind of a problem. Let's get it taken care of. Anesthesia-wise, your operation generally involves anesthesia. Local anesthetic has very minimal risks, but if you're allergic to lidocaine or bupivacaine in the dental office, we need to know that because that's what we're generally using, something related to that. General anesthetic and sedation procedures have risk of anesthesia as well. We're generally evaluating that in the clinic as we go along with the surgery evaluation, and patients with high risk are generally done in the hospital setting. Patients with intermediate risks and low risks are in this outpatient setting. But that's part of why we're doing blood tests and EKGs in evaluation before surgery. And sometimes you'll be set up for an outpatient surgery, and those tests will either cancel the surgery and require a cardiac evaluation, or change the setting of the surgery, or tell us something else needs to be done before the operation is done. But we deal with, in the outpatient setting, minimizing the anesthetic risk and getting you through the operation as smooth as possible. You'll be speaking with the anesthesia provider specifically about your situation the day of surgery before you go in for surgery. If you have sleep apnea at baseline, we do ask you to bring in your CPAP mask because that can be helpful in the recovery phase when you're not breathing so well and when you're not as awake, sort of like it helps you at night. Medications that we give after surgery can have reactions too, particularly if you've never seen them before. If you've had problems with certain pain pills before, we need to know that up front so that we don't get you into the same trouble that you had before. But generally, narcotic pain medications are constipating. And the number one distress call I get is usually 4 days after surgery. Somebody hasn't thought about how their bowels are working. They've had their surgery, they're doing okay, but now they can't poop. And it can be the most miserable part of your operation if you're bloated after an abdominal surgery and you can't poop and you have to push it out, and nobody wants to give you an enema. So you need to be proactive on that. So the night of surgery, drink plenty of liquids. When you're starting to eat, don't jump into meat and potatoes. Instead, fruit and vegetables. You want lots of fiber in your diet that will help you with your bowels in that immediate postoperative period. And If you're a constipated person in the first place, clean out before surgery, take laxatives, and keep your bowels working. You would rather have the trots in 2 days than bricks in 4. But certainly keep an eye on it. If you normally have really good bowels, you don't even have to think about it, be thinking about it. If you haven't had a bowel movement in 2 days, you need to take a laxative and get things going and make sure that you don't get bound up. That's the best way to have a smooth operation after the operation. So when it comes to complications, nobody can tell you all the possible complications. There are a number of things that can go wrong. Your informed consent forms will give you a lot of answers there. But generally speaking, the more experienced your surgeon is, the less complications you're going to have because they've seen things before, and that experience helps them keep their patients safe. So at Meridian Surgery Center, you'll see a lot of experienced surgeons and providers at your bedside, guiding you through your operation to minimize your potential for infection.